Good morning, everybody. Many thanks again for inviting me to come and talk to you. This morning's talk I'd like to give you is about a global perspective on antimicrobial management and stewardship teams. Today, the WHO are actually meeting to hopefully ratify the antimicrobial resistant action plan that many countries actually had contributed to. And they were really trying to look at five key areas within this. Firstly, they were looking at increasing antimicrobial resistance awareness through effective communication, education and training. They want to strengthen the knowledge and evidence base through surveillance and research. They want to reduce infection through improved prevention, better sanitation and hygiene measures. And the bit that we've been focusing on today has been very much about optimization of use of antimicrobial medicines in human health, but also in animal health. They also want to try and develop an economic case for sustainable investment that takes account of the needs of all countries and increase investment in new medicines, diagnostic tools, vaccines, and other interventions. So specifically looking at the optimization of use of antimicrobials in both humans and animals, they want to actually identify that resistance is driven by use and increasing due to over-the-counter sales, internet sales, and the increased use of antimicrobials in food production. They also highlight that usage data is lacking at patient level, and in some of the lower income countries, it's not available even to national level. And one of the big drivers that they want to see is actually getting the world to recognise antibiotics as a public good, and they want to see much better strengthened regulation to try and stop some of the counterfeit antibiotics that we see throughout the world. And most importantly, I think, is the decisions to prescribe are rarely based on definitive diagnoses, and we need to come up with some cheap tools to try and help this. And finally, evidence-based prescribing and dispensing should be the standard. If you look around the world, there are numerous initiatives going on around antimicrobial resistance. But I ask you, have any one of you actually seen a worldwide standard of what should be in an antimicrobial stewardship program? No. And that's one of the big sort of problems. You go from one country to the next, and we have no idea what should actually be in the program. So this led a joint survey to be taken place through the European Society of Clinical Microbiology and Infectious Diseases and the Guidelines and Policies Group, which is effectively the Antimicrobial Stewardship Group, and the International Society of Chemotherapy. And this is the paper we had published online back in December. I'd like to take you through the results of this. So previous studies had looked specifically at country level or continental level only. And the project group took what published standards and definitions and previous surveys that had been used. And what we aimed to do was measure the extent and components of the global efforts in antimicrobial stewardship. We pulled together quite an extensive survey. It had 43 questions in it. We piloted it in 11 countries across 6 continents and then distributed it through various networks. And we used an online SurveyMonkey software. And we did this, started the rollout in spring through 2012. So one of the first things we looked at was actually countries that actually had antimicrobial stewardship standards. And you might argue, without the standards at a national level, how can you actually expect individual hospitals to try and drive that? And you can see that across the world, there were 52%, so just over half, that actually had standards in place, with a further 4% developing them. And you can see there was huge variation across the world. Europe had 81%, then down to Oceania, so Australia, New Zealand at 50%, South America at 42%, along with Asia. North America, surprisingly, with only the USA having standards in place at 20% and Africa at 20%. We also asked whether you had a program at hospital level, and we had 667 hospitals around the world actually fill the questionnaire in. And just over half actually had an antimicrobial stewardship program, and a further 22% were actually sort of planning one. And again, you can see the large variation across the world, with North America, then Europe and Asia having the most in place. And in some of the more lower income continents, such as Africa, it was much less. And you can see in the bottom right-hand corner that the actual duration of these programs are fairly young. They've only been around on average for 3 years, and this varies between 5 years in Europe down to just a year on average in Africa. Now, one of the things we actually asked was, what were the 3 key objectives of a current or planned program? And uniformly across the world, we actually saw that reducing or stabilizing resistance was the main driver, followed by improving clinical outcomes, reducing the amount of antibiotic prescribing, and then reducing healthcare-acquired infections. And there was very little difference across all the continents. The only thing that really stuck out was, very much in Europe, there was a driver to reduce healthcare-acquired infections. And I think that was strongly influenced by the UK's results, where there has been a really firm driver to drive down Clostridium difficile. We also asked, what were the main barriers to providing a functional and effective stewardship program? Now, overwhelmingly in those who currently have a program and those who are planning one, you can see at the bottom of these bar charts, it was a lack of personnel. But those who actually had one in place already, there was also problems with a lack of information technology or able to get data to try and support it. And one of the things which is quite staggering here, and this is one of the big challenges I think we all have, is actually opposition from prescribers. And that's going to be one of the big elements. If we actually look at some of those who had a planned program, the second highest reason for actually being a barrier was other higher priority initiatives. Now, the information I've heard over the last 3 days so far about antimicrobial resistance, I can't really think of any higher priorities and antimicrobial resistance. And this is why the WHO are talking about it today, get the plan rolling out. So we have to sell our message back at base. We asked what governance arrangements were in place, and we've seen some of the data yesterday from the Gulf, which was quite similar. So drug and therapeutic committees were fairly common across all continents. But actually, when it came down to looking at who had an antimicrobial stewardship committee in place, it was just over half, and it was more commonly seen in Europe, North America. But when we talk about things about, do we have a stewardship strategy, and do we actually share the results of what we have achieved within our institutions, you can see the numbers drop less than half. And certainly, the numbers that actually have a published plan, so telling everybody what we're going to do, is only a quarter. So unless we communicate effectively, we're not going to get the message over saying what we want to try and achieve. Again, policies on here varied with just over half, and Europe had the most with 73%. Formularies were fairly common. Antimicrobial treatment guidelines and prophylaxis guidelines, again, very common. Automatic stop review policies were fairly low. Reserve antibiotics were in about 2/3. And then advice from microbiology infectious diseases by phone was relatively common, 77%, but ward rounds at 50%, and proactive bacteremia services in just over half. Some places actually did see a bit of dose optimization, some of the roles of the pharmacists going on here, and this has been really well developed in the USA. When we looked at some of the diagnostic tools to avoid starting or stopping antibiotics early by things like the use of procalcitonin, again, this was particularly low. And then the ability to link lab results from the lab to actually what's being prescribed was really low, only 13%. Now, this is a really complicated slide, and I've tried to summarize it at the bottom. We did ask, what was your average team that looked like? And the top one shows that your average team provides about 18 hours of an antimicrobial pharmacist, 10 hours a week of infectious diseases, 9 hours a week of a medical microbiologist, 8 hours a week of infection control nurse, and so on. But actually, you look at a continental sort of approach to it, then within USA, Australia, and Asia, it was pharmacy and infectious diseases working, leading in it. Whereas in the UK, it was very much a pharmacy and a microbiologist approach. And then across non-UK Europe and South America, it was very much an infectious diseases-led approach. And in Africa, it was very much about nurses leading the approach. So there's lots of different ways of sort of doing this, but whatever works in your country is probably the best way of actually getting it to take place. We've heard quite a bit about antimicrobial stewardship, sort of ward rounds, and you can see the approaches that have gone on here. ICU tend to happen mainly sort of on a daily sort of basis, and medical ward rounds do vary considerably between daily sort of and weekly, and less commonly on surgical and paediatrics. When we asked about those effects, those ward rounds on consumption, that it was only the surgical ward rounds that actually said they decreased consumption, where everything else stayed the same. We asked a few questions about antimicrobial restriction and reporting. 80% of respondents said they restricted antibiotics in some way. Carbapenems were the most commonly restricted, 73%, fluoroquinolones, 63%. And those areas that had big concerns about Clostridium difficile tended to restrict cephalosporins. And then 65% pharmacy followed up restricted antibiotics that had been issued. Now, a very small number practiced diversity, so this is a deliberate mix of antibiotics to try and not sort of push resistance against a particular class of antibiotics, and a very small amount actually cycled antibiotics. Now, one of the biggest challenges we've got is electronic prescribing, and you can see only a fifth of the respondents actually reported it, and it varied from 2% in Africa up to almost 40% in North America. Now, most places did manage to report antimicrobial usage. A lot of it was either at expenditure level or defined daily doses, and occasionally about 2/3 put defined daily doses per occupied bed day at hospital level. But as we moved down to a specialty level, we certainly saw lower values. Now, surprisingly, almost half, or just over half, actually linked these to resistant rates, and just under half are linked them to infection rates, and that was quite good to see. We also asked questions about how do you communicate, and I think this varied about how well developed the individual sort of countries were. And so there was the more sort of the richer continents generally tended to use the intranet for communicating about empiric guidelines, directed guidelines, surgical prophylaxis, and the formularies. And those who weren't quite so well evolved at using IT were using sort of booklets, but these can often go out of date, and you need to have to keep on replacing them. When it comes to about sharing things about antimicrobial usage, antibiograms, and learning from incidents, this was done in staff meetings, and I would challenge all of us is, actually, how does the information in a staff meeting get to the whole of the population who work within a hospital if it's not available? We've heard a lot about education. Now, just under 90% of hospitals educated their healthcare staff, and 96% of them actually educated their senior and trainee doctors. And you can see that most of it was done by face-to-face, and lower levels actually received written information, and it was very much induction. And about a third actually provided short courses. The good news was, I suppose, it was only a very small number that didn't educate their doctors. But only a quarter of them actually had mandatory updates, and we have to challenge ourselves to how do people keep up to date. Now, nurses, I think, are key to all of the elements of antimicrobial stewardship, because they are the ones who actually administer the drugs and go on the ward rounds with doctors, and can be used very usefully to challenge whether we need antibiotics or not. And not very many of them receive education. 27% face-to-face, 16% given written information. And so there's not a lot there. Pharmacists are very similar to doctors. They get a lot of education, and face-to-face is the most common way of doing it. And e-learning, so even though we've got some of the technology coming along and the ability to use e-learning and test whether people have learned, it's actually used in quite a small number. So one of the things we do like to ask is actually, do we do some audits to see if people are actually following guidelines or things like that? And you can see that 80% did any sort of audit that sort of took place. And you can see the more common ones that were sort of taking place were things like surgical prophylaxis, compliance to sort of guidelines, indication durations on drug charts. But the things that really affect outcome to patients, can we make a difference to survival rates, like time to first dose in sepsis, is done in about only a third of sort of patients. And then there's outcome of the day 3 review. So one of the major interventions for antimicrobial stewardship is done in a much smaller sort of level. So I think there's certainly more work to be done around the world. And so we asked everyone who took part, had they done a formal review of their antimicrobial stewardship programs, and to see what sort of benefit they'd sort of shown. And you can see the most common things is that almost everybody had shown they'd reduced inappropriate prescribing. 86% reduced the usage of broad spectrum agents. 80% had actually reduced expenditure on antibiotics. 71% had reduced healthcare-acquired infections. And surprisingly, 58% claimed they'd actually had an impact on antimicrobial resistance. So in conclusion, I think despite all the inherent limitations, response bias, convenience of sampling, I think this survey suggests that antimicrobial stewardship can actually reduce probably antimicrobial resistance and expenditure. And we hope that this survey should encourage a strategy to promote the worldwide antimicrobial stewardship programs. And I'm certain that WHO today will actually sign off their global antimicrobial resistance plan. And we will all have a really important role in actually trying to get that plan to roll out and getting embedded worldwide. Now, a survey across the world is very difficult to do on your own, and there are a lot of thank yous to take sort of, people I need to thank, and they're listed sort of here. And I'd like to thank everybody in the audience who actually took part from the sort of the Gulf states in completing it. I know it took about 3/4 of an hour at least to do it, and that was well appreciated. Thank you very much.